Okay, recording. Sir,
Yes,
you can start the class, sir.
not visible. Okay, fine. Should we start?
Yes, sir.
Okay. Hello, everyone. Very good evening to all of you guys. Myself, Dr. Vaibhav Jain, and today we will be discussing about the respiratory system, right? This is the continuation of the same live classes series that we are having. We are already done with the GIT system, and today we will be starting off with the respiratory system, right? So, what are the things you should be knowing before starting of the respiratory system? This is a 90 days university pre-final prof mastery program that we are having in the Oracle, where you will be getting all the questions. We will be discussing about the long essay questions, short essay questions, and also the short answers, right? Why to choose Oracle? You will be getting those recorded classes that you can see later on. You will be having live classes like this. You will be having practical sessions that are going to help you in your examination. You will be having exam module. What is that exam module? You will be getting rapid revision session of like just before your examination. You will be getting that, and hard copy notes will also be provided, right? This is a recorded class, right? You can always go back and see whatever topics that are going on in your university, right? These are your live classes that we are taking, where we will be discussing how to solve the question, what are the different type of questions that are coming, and what are the important things that you have to write, right? And these are your express exam module, where you will be getting a rapid revision that you can see just before your examination, right? Just 20 hours of rapid revision for a quick revision, right? And in the superior plans, you will be getting one-to-one doubt clearing session, where you can directly ask your doubt to the mentors, right? Directly you can connect with the faculty, right? You will be having these hard copy notes, which are very useful, and you can always assess yourself with the help of these question banks, right? These question banks are going to help you not just only in the university prof exam, but also in the NEET PG and FMG exam also, right? These are your practical sessions going to be very helpful. These are our plan. We are having like foundation plan, advanced learning plan. We are having complete learning plan. We are also having this ultimate MBBS plan, where you will be getting all the things for like 4 years, right? Throughout your journey, right? Myself, Dr. Vaibhav Jain, and today we will be discussing about the respiratory pharmacology, right? What are the drugs we are going to discuss? What are the things you will be giving in the cases of respiratory diseases like bronchial asthma and upper respiratory infections like cough, right? So we will be understanding from the basics. I will make you understand what is a cough, what are the different questions that can be asked, and we will be discussing about all those things, right? So this is a long essay question that you will be having. Drugs we are using in bronchial asthma, what is the mode of action, what are the adverse effect, what are the effects, right? So before starting that, let me make you understand what is the asthma, right? First of all, you should be knowing what is a asthma. So what is asthma? Write down asthma. So asthma is a chronic, it is a chronic inflammatory disease. It is a chronic inflammatory progressive disease, right? It is a chronic inflammatory progressive disease that is happening because of what? It is mediated by, it is mediated by IgE antibodies. It is mediated by IgE antibodies. And what is the main problem that is happening? These IgE antibodies are going to constrict your bronchus, and you will be having that bronchoconstriction. Because of this, what is going to happen? It will be having like release of histamine. I'm going to make you understand the basic physiology, pathology around it, right? So it will be causing, basically, it will be causing narrowing, narrowing of your airway. So it will be causing narrowing of your airway, and you will be having problem in the breathing. You will be having problem in the breathing, right? This is a type 1 hypersensitivity reaction. 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 What are the different causes? If we talk about the causes of asthma, why asthma is happening, so it can be genetic, it can be having family history, it can be due to environmental factors like allergens will be there, pollens will be there, molds will be there. So all those factors can cause asthma. So this can be, what are the factors? So genetic factors can be there, family history can be there, family history of atopy, right? Other factors can be there. What are those other factors? Those factors are like environmental factors, like it can be due to air pollution, it can be due to smoking, can be due to dust, some kind of mold, fungal infections, mold. Okay, it can be due to medications. There can be multiple causes, right? It can be due to medications also, right? I'm going to make you understand what medications, right? So basically, what is the basic pathology around it? So this is your normal airway. Now, what is going to happen in asthma? You will be having contraction of the airway, and during the asthmatic attack, you will be having narrowing of this airway, right? Narrowing of this airway will lead to what the patient will present to you with the dyspnea, right? Patient will be having dyspnea, right? Patient will be having cough because of this narrowing. And why this narrowing is happening? Because of some allergens. So let's try to understand what are the allergens and what they are going to do. So for example, any allergen that is coming, it is going to stimulate the goblet cells. You will be having mucosa. In mucosa, you will be having what? You will be having goblet cells. You will be having goblet cells in the mucosa. And these goblet cells will be producing what? They will be producing mucus. So you will be having increased in the mucus production, right? And this increase in the mucus, increase in the secretion is going to cause what? Narrowing of the airway. This is going to cause the narrowing of the airway. First thing. Second thing, these allergens are going to bind with the IgE type of antibodies, right? We are going to have what? Mast cells. These are your mast cells. Remember what mast cells are secreting? Mast cells are secreting histamine, right? Mast cells will be secreting histamine, prostaglandins, leukotrienes, right? So how these mast cells will be getting activated? They will be having what? They will be having these IgE antibody. So it will become these IgE antibody are going to bind with the mast cell. Now what is going to happen? Whenever you are going to have those allergens, these allergens are going to come and bind to these IgE antibodies. And this IgE antibody, now what this IgE is going to do, it is going to bind with this mast cell, and now you will be having rupture of mast cells. And whenever there will be rupture of mast cell, what is going to come? You will be having release of histamine, you will be having release of prostaglandins, you will be having release of leukotrienes. Remember, leukotrienes are the most powerful bronchoconstrictor, right? Leukotrienes are the most powerful bronchoconstrictor. So whenever a allergen will come, it is going to bind with the mast cells. It is going to bind with the IgE. IgE is going to bind with the mast cell, and you will be having what? Mast cell rupture will be there, and this rupture is going to cause what? Release of histamine. Histamine has two important functions from your physiology. You must be knowing. It will be causing bronchoconstriction, it will be causing vasodilation, right? So here we are concerned with the bronchoconstriction part, right? Again, this allergen is also going to bind with the antigen presenting cells. Antigen presenting cells, or you can call it dendritic cells. What this dendritic cells are going to do? These dendritic cells are going to activate your T helper 2 cells. These are going to activate your T helper 2 cells. And whenever there will be activation of this T helper 2 cells, it will be releasing some interleukins, right? What are the important interleukins that we are having? It is going to release interleukin 4, interleukin 5, and interleukin 9, right? What are the function of this interleukin 4, interleukin 5, and interleukin 9? This interleukin 4 is again going to increase your IgE antibodies. It is going to increase your IgE antibodies. Now you will be having more IgE IgE mast cell complex. You will be having more IgE antibodies. You will be having more mast cells. You will be having more inflammation. You will be having more release of histamine, more release of prostaglandin, more release of leukotrienes, right? Second thing, what it is going to do, it is going to increase your eosinophils. Interleukin 5 is going to go to your bone marrow. It is going to increase the eosinophil, which is a type of granulocyte, which is a type of WBC granulocyte, right? And interleukin 9 is going to increase the mast cells. It is going to increase the mast cells. So basically what is happening, you will be having more Ig, you will be having more mast cells, you will be having more histamine, prostaglandin release, you will be having more bronchoconstriction, right? So that is what is you have to remember. This more IgE will lead to increase in the mast cells, and this mast cells are going to increase the histamine, and this is going to present with the bronchoconstriction. This particular thing is going to present with the bronchoconstriction, right? So these are the stimulating factor. These are the factors which are going to cause the disease. This is the basic pathology that we are having around this particular disease, right? What are the symptoms? What are the clinical features that you will be finding? So for clinical features, what are the clinical features? First thing, you will be having what? You will be having increase in the secretion. Because of this mucus, there will be increase in the secretion. What is going to happen? You will be having what? The patient will be having what? Cough. Patient will be having cough. Second thing, if there is narrowing of the bronchus, if there is narrowing of the bronchus, you will be having some sound coming, right? If you are narrowing some vessel, what is going to happen? It will produce some sound. So what kind of sound you will be having? You will be hearing wheezing. Wheezing is a feature of bronchial asthma. Wheezing is a feature, right? Third thing, you will, when you are inhaling the air, now what is going to happen? The bronchus is constricted. That means what? You will be having decrease in the air supply to the lungs, and you will be having what? You will be having dyspnea. Dyspnea. You will be having dyspnea, right? So these are the clinical features you will be finding. You will be having uh, tightness in the chest. You will be having tightness in the chest. These are the features you will be finding. Sometimes you will be having flushing. Why this flushing is happening? The flushing is happening because of vasodilation part of the histamine. Remember what I've told you, histamine will be having, this particular histamine will be having two important functions. One is vasodilation, second is bronchoconstriction, right? Prostaglandin, it will be having functions. I have already taught you. It will be causing pain, it will be causing fever, it will be causing inflammation. Prostaglandins are concerned with the pain, fever, inflammation, and increase in the mucus blood flow, increase in the mucus production. So here we are having two important function of this prostaglandin. This is first one, inflammation. Second one, it will increase the mucus production. It will increase the mucosal blood flow, leading to increase in the mucus production, right? This leukotrienes are concerned with exaggerated bronchoconstriction. They are most powerful bronchoconstrictor. They are most powerful bronchoconstrictor. They are most powerful bronchoconstrictor. So it will be causing, ultimately you will be having what? The main pathology will be narrowing of the airways, right? If I want to talk about the problems, what are the problems you will be having? The main problem is what? Bronchoconstriction. Bronchoconstriction, and this bronchoconstriction is because of what? Because of these multiple factors. You will be having this bronchoconstriction. This particular thing is IgE mediated. So we will be discussing about the IgE antibodies are the problem. And third problem is your mast cells, because these are the mast cells which are going to secrete what? Histamine, prostaglandin, and leukotrienes. So these are the problems, and we will be focusing on the problems. We are going to block this, and that will be the treatment for our situation, right? From the pathology, what kind of, when you go for sputum examination, this is an important question they can ask you. For sputum examination, you will be finding what in the sputum? You will be having Seriola bodies. You will be having Trussman spirals. Trussman spirals. You will be having Charcot Leyden crystals. Charcot lead crystals. So these are the important finding that you will be finding along with the this particular disease, right? So this is a case study that we are having. This is a case we are having. So what is the case is saying? Look here, a 13-year-old female patient is presented to the OPD with the complaints of patient is having what? Cough. Since how many days? Since 2 weeks, patient is having cough. Patient is having shortness of breath. Shortness of breath, that is nothing but your dyspnea. Okay. Patient is also having what? She's also having what? Wheezing since last 1 week. And there is chest tightness is also present. These are the keywords you need to identify when you are going to look at the cases. We are going to discuss lots of cases in every chapter. So this is going to be chest tightness will be there since 2 days. And the chest X-ray is revealing what? Can you appreciate? These are hyperinflated lungs. These are hyperinflated lungs. You will be having these bronchial vesicular markings are visible. How you can differentiate it with the COPD? COPD will be having this type of appearance. Tubular appearance will be there. There will be decrease in the size of heart, right? This diaphragm is normal here. It is differentiated with the COPD, right? So this is a case of asthma. This is a classical case of asthma. Why? Because you are already finding the cough. We are having what? Wheezing. We are having wheezing, we are having cough, we are having chest tightness. Okay, so the diagnosis, our diagnosis will be, it is a case of asthma. It is a case of asthma. How you are going to treat the case of asthma? Let's learn about the treatment part, right? Let's learn about the treatment part. What is the treatment we are going to give here? So for the treatment part, first problem that we are having is the bronchoconstriction. First problem we are having is, sir, bronchoconstriction is there. Okay, Vichi, we are having bronchoconstriction. So what we are going to do for treatment of bronchoconstriction, we are going to give bronchodilators. We are going to give bronchodilators first, right? What are the different classes of bronchodilators we are having? We are having drugs like beta 2 agonist. Remember, beta 1 is present on the heart and kidney. It will be releasing in the heart, it will be activating your SA node, your AV node, your muscles, right? And in kidney, it will be releasing renin, right? So that is the beta 1. Beta 2 is present in the bronchus. It will be causing what? Bronchodilation. So whenever we are activating beta 2 agonist from your ANS knowledge, whenever we are activating beta 2, what is going to happen? We are going to have what? Bronchodilation. We are going to have what? Bronchodilation. What are the examples we are having? We are having drugs like SABA. These are your short-acting beta agonist. We are having drugs like LABA. These are your long-acting beta agonist, right? What are the example? If I want to give you example, this is your salbutamol, or one from the LABA, that is formoterol. Formoterol. These are the drugs we are going to use as a bronchodilation. These are fast acting, so we will be having, for acute cases, we can give this drug and you will be having instant relief, right? Within like 5 minutes, like salbutamol will start to work within 5 minutes. It will be remaining for like 2 to 4 hours. So that is how we can use it, right? Second bronchodilator we are having is class of methylxanthines. Second class of drug we are having is methylxanthines. Methylxanthines, what are the examples we are having? We are having drugs like aminophylline, theophylline, aminophylline, drugs like theophylline. So how they are going to work? Basic understanding, they are going to inhibit the phosphodiesterase enzyme, leading to increase in the levels of cyclic AMP, right? We have drugs like, these are basically phosphodiesterase inhibitors. I'm going to make you understand what is the mechanism of action also, right? Third class of drugs we are having, we can use anticholinergics. Anticholinergics. right? We have discussed like cholinergic or parasympathetic nervous system will cause bronchoconstriction. So what we can do, we can give parasympatholytic drug. Opposite to that, we can also call it parasympathetic is also known as cholinergic because the neurotransmitter is acetylcholine. So we can use drugs like anticholinergic. So what is going to happen whenever we are going to give anticholinergic drug, what is going to happen? It will be having what? Bronchodilation. The patient will be having bronchodilation. What are the examples we are having of anticholinergic drugs? These are your ipratropium bromide or tiotropium. Ipratropium bromide or tiotropium. So these are the drugs. First thing, there is bronchoconstriction in asthma. We can give bronchodilator. Apart from the bronchodilator, second drug that we are having, these are the steroids. These are your steroids. What kind of steroids we can use? So we can use two types of steroid. Either we can give it systematically, that is oral. Either we can give inhalational corticosteroids, right? So we can use it systematic steroids. Systematic steroids like your hydrocortisone. We are also having drugs like prednisone. We can give prednisolone, right? These are the drugs we are having for the systematic effect, right? Systemic. These are the systemic drugs. Okay. Second we are having is inhalational drugs. Second we are having is inhalational drugs. So what are the inhalational drug that we are having? We are having inhalational corticosteroids. These are your beclomethasone, budesonide. Okay. So these are your drugs like beclomethasone. We are having drugs like budesonide, right? So these are the drugs we can use for the steroid. These are the steroids, right? Apart from steroids, we can block the leukotrienes. What is happening? What are the problems? Let's identify the problems. The problems are one of the problem is leukotrienes. First thing is your bronchoconstriction. We have discussed about the bronchodilator. Second problem we are having like histamine and leukotrienes. They are causing the bronchoconstriction. And remember, leukotrienes are the most powerful bronchoconstrictor. So we are having drugs like anti-leukotrienes. So we are having class of drugs. These are your anti-leukotrienes. We are having a class of drug. These are your anti-leukotrienes. So what are the examples? We are having like 5-LOX inhibitor. We are having like leukotriene receptor inhibitor. I'm going to make you understand, right? So this is your leukotriene inhibitor. What are the example? We are having drugs like xilutone. This is a 5-LOX inhibitor. We are having drugs like montelukast, your favorite montelukast. We are also having drugs like zafirlukast, right? Zafirlukast, montelukast, these are the anti-leukotriene drugs, right? Fourth drug is going to work on the, we can stabilize the mast cell. So everything is coming from the mast cell, so we can give mast cell stabilizers. Can I use mast cell stabilizers? Yes, we can use mast cell stabilizers. These are drugs like needochromal, and sodium chromoglycate, ketotifen. We are having multiple drugs, right? These are your important ones. Neopromyl, sodium chromoglycate. They are going to stabilize the mast cell. They are going to stabilize the mast cell. Suppose this is a mast cell. Now, if the mast cell is not getting ruptured, what is going to happen? You will be having no histamine. You will be having no leukotriene. You will be having no prostaglandin. You will be having no bronchoconstriction, right? So these are mast cell stabilizers, right? They will be stabilizing the mast cells. I'm going to make you understand how. And lastly, we are having what? Monoclonal. Lastly, we are having monoclonal antibodies. What are the examples? We are having drugs like omalizumab. This is your exam question. Omalizumab. We are also having drugs like duplimab. Dupli Dupli map. Remember, all the monoclonal antibodies will be having MAB in the last. They are generally given subcutaneous. We cannot give them oral, right? So they are generally given subcutaneous. This duplimab is basically going to inhibit interleukin 4 and 5. Interleukin 5 inhibitor. This is what we have seen, right? Interleukin 4 and 5 is going to do what? It is going to increase your IgE. It is going to increase your eosinophils. So we can decrease it with the help of this monoclonal antibodies, right? These are your monoclonal antibodies. Omalizumab is a anti-IgE thing, right? It is going to inhibit interleukin 4. It is going to decrease the levels of IgE. If there is less IgE, what is going to happen? If there is no IgE or less IgE, what is going to happen? There will be less binding of the allergen. There will be less response from this mast cells. Less response from this mast cells. What is going to happen? You will be having less symptoms, right? So this is the classification of for the treatment of the for the treatment of bronchial asthma. We are having these drugs. Let's revise. We are having bronchodilators. Why? First thing, what is happening? Because of bronchoconstriction, the patient is not able to breathe properly. Patient is having dyspnea. Patient is having cough. Patient is having wheezing, right? So we can dilate the vessels, we can dilate the bronchus, right? Second thing is steroids. Steroids, I'm going to make you understand, they are basically they are inhibiting phospholipase A2 enzymes. These are phospholipase A2 inhibitor. Just remember this for now. I'm going to make you understand. They are going to inhibit the phospholipase A2. So what is going to happen? There will be no prostaglandin. There will be no leukotrienes, right? So it is going to stop prostaglandin and leukotrienes. Anti-leukotrienes, they are specifically working on the leukotrienes. We are having 5-LOX inhibitor, that is Gilotone. We are having drugs like Montelukast, Jafelukast, and mast cell stabilizer, because everything is coming from these mast cells. So if we can stabilize these mast cells, what is going to happen? You are going to have decrease in histamine, decrease in prostaglandin, decrease in leukotrienes. Everything will be fine for you, right? And monoclonal antibodies, they are going to inhibit the IgE. They are going to inhibit the IgE. These are your interleukin 4 and 5 inhibitors also, right? So these are the important things about the treatment part. Now let's try to understand what are the different drugs we are having. Short essay question that you are having. What are the different drugs we are having and how we are going to treat the patient? What are the adverse effects? What are the uses of these drugs? So we are having selective beta 2 agonist. First thing we already know, beta 2 is responsible for what? Beta 2 is going to cause bronchodilation. Beta 2 is going to cause what? Bronchodilation. So they are bronchodilators. They are bronchodilators, right? And they are most effective drug. They are most effective drug and they are the fastest. They are most effective and fastest drug, right? These are the common points. How this thing is going to work, remember, this beta 2 agonist is going to cause bronchodilation, right? This is what we know. How it is going to cause bronchodilation? Basically, it will increase the cyclic AMP. It is going to increase the cyclic AMP, and this cyclic AMP is going to play two major role. First one, it will dilate the bronchial smooth muscle. It will dilate the bronchial smooth muscle, so it will be causing bronchial muscle relaxation. Second thing, it is going to decrease the inflammatory mediator. It is going to decrease the inflammatory mediators, right? So this is how it is going to produce the bronchodilation effect, right? What are the examples we are having? We are having drugs like SABA. We are having drugs like SABA. What are the examples of SABA? We are having drugs like salbutamol. They are salbutamol is a short-acting beta agonist. Salbutamol. We are also having drugs like albuterol. We generally call it same. This is your albuterol. We are having drugs like terbutaline. Remember, terbutaline, we can use it in the syrups also. So those syrups you are having, it will be also having the bronchodilator property. This is your terbutaline, right? The effect will be coming within 5 minutes and it will be retaining for like 2 to 4 hours. They are short acting, whereas long acting ones are your, these are known as LABA. Long acting are known as LABA, long acting beta agonists. These are having, these are the drugs. We are having drugs like formoterol. We are having drugs like salmeterol. So you can remember in their name we are having what? Metro, and you can remember metro is long, so they are long acting drug. And one more thing you can remember for this formoterol, F for formoterol, it is a long acting. You can remember second thing F4, it is the fastest also, right? It is the fastest also, and it will be having action like for up till 12 hours. It will be remaining active for like 12 hours. SABA are short acting, they will be working for like 2 to 4 hours, whereas LABA are long acting beta agonists, they will be working for like 12 to 12 hours, right? What about the common side effect? They will be asking question on the common side effects. So beta 2 agonist, the common side effect will be there will be tremors, there will be palpitation. So what is tremor? Tremor is the excessive contraction of the skeletal muscle. Whenever there is excessive contraction of the skeletal muscle, we call it tremor. What is palpitation? When there is excessive contraction of cardiac muscle. Excessive contraction of cardiac muscle, that is going to be your palpitation, right? So this particular drug is having this particular side effect. We can use it for the early users, right? They are the fastest one, right? Second question that we are having is about the theophylline. So theophylline or caffeine, we can also uh, think in the terms of like black coffee, it is having what? Caffeine. These are the same derivatives we are having. They are the derivatives of methylxanthine. They are coming under the class basically methylxanthines. They are also increasing this. They are also having the same function. What is the function? So this ATP is going to convert into cyclic AMP, and this cyclic AMP is going to break down. It is going to break down with the help of an enzyme. What is that thing? This is your phosphodiesterase. This is your phosphodiesterase. And now what we are doing? Now we are blocking this phosphodiesterase. Now we are blocking this phosphodiesterase. What is going to happen? If I block this enzyme, because it is metabolizing the cyclic AMP, if I block this, what is going to happen? The levels of cyclic AMP will be increased. If I block phosphodiesterase 3 or 4, what is going to happen? You will be having increase in the levels of cyclic AMP. And if there is increase in the levels of cyclic AMP, we have already discussed, it will be causing increase in the bronchodilation, and it will be causing decrease in the inflammatory mediators, basically. Decrease in the inflammation, because it will be decreasing the inflammatory mediators, right? So ultimately the function will be same, but the action will be here. These are your phosphodiesterase inhibitor. What are the examples we are having? We are having drugs like theophylline. We are having drugs like aminophylline. Remember this aminophylline we can use for the acute exacerbation of asthma. We can use it for the acute exacerbation of the asthma attack, right? We can use aminophylline. Whereas this particular theophylline, this particular drug has narrow therapeutic index, right? So we need to monitor the dose also, right? So we cannot use them. We will be using them, but not in a higher doses, right? So because it will be having low therapeutic index, it will be having low therapeutic index. Okay. What are the side effects you will be having here? The normal side effect that you always writing is about nausea, vomiting, but the particular side effect that you need to remember, they can cause arrhythmias in the patient, not in the normal dose, but in the high doses, they can cause arrhythmias. They can also precipitate seizures. These are the specific side effects you have to remember, right? So we are not very commonly using this theophylline drug, right? Next, we are having in the list is your leukotriene antagonist. What is the meaning of this leukotriene antagonist? So we are having like, let me make you understand. We are having all the cells you must have studied in your physiology. That cell is the basic structural and functional unit of body, right? So all the cells will be having phospholipid bilayer. Yes, all cells will be having phospholipid bilayer. So whenever there will be a cell rupture, what is going to happen? This phospholipid bilayer will be acted upon by an enzyme, that is your phospholipase A2. Phospholipase A2, and it will be making what? It will be making arachidonic acid. It will be making arachidonic acid. And now, when this arachidonic acid, it will be acted upon by two things. One is your COX enzyme, Another one is your LOX enzyme, right? Another one is your LOX. So when the COX will be working, it will be making things like prostaglandins, prostacyclins, whereas when the LOX will be working, it will be making things like leukotrienes, LTC4, D4, B4. We will be discussing in the auto quiz, but just remember this one, right? So if I want to block these leukotrienes, remember these leukotrienes are the most powerful bronchoconstrictor. It will be causing bronchoconstriction, and this prostaglandin, it will be having functions like pain, fever, inflammation will be there, and increase in mucus, right? So what we want to block this increase in the mucus, we want to block this inflammation. So what I can do, I can use COX inhibitor, right? But whenever we are using COX inhibitor, what is going to happen? This particular pathway will get overactivated. This particular pathway will get overactivated, and what is going to happen? You will be having more leukotriene formation, and more leukotriene formation will lead to asthma again, right? So this particular thing is known as aspirin induced asthma. So whenever person is taking aspirin, what can happen? This aspirin is going to block this COX. What is going to happen? This pathway will be upregulated, and whenever this pathway is going to upregulated, you will be having leukotrienes. More leukotrienes, more leukotrienes will lead to more bronchoconstriction. More leukotrienes will lead to more bronchoconstriction. Second thing, the two drugs that we are discussing, one is your leukotriene antagonist. This is a receptor, so we can use drugs like montelukast. Montelukast, these are your leukotriene receptor antagonist, right? These are going to work on the receptor. These are montelukast or zafirlukast. Second drug we are having is your LOX inhibitor. LOX inhibitor is your zilutone. Zilutone is the drug which is a LOX inhibitor. If I want to block the complete pathway, what I can do, I can block this particular enzyme. This is your particular enzyme. It is getting blocked with the help of what? Yes, yes, this is your steroids. So all the steroids that we are taking, they are going to block this particular pathway, phospholipase, this particular phospholipase A2. Now what is going to happen? This phospholipase A2 is blocked. Now there will be no COX. Now there will be no LOX, right? No COX means what? No prostaglandin, no pain, fever, inflammation, no mucus production, right? LOX means what? If LOX is blocked, you will be having no leukotrienes. No leukotrienes means no potent vasoconstriction, bronchoconstriction, right? So we can utilize these drugs. These are your anti-leukotriene agents. Leukotriene agents, we are having first drug, that is your zilutone. This is a 5 LOX inhibitor, or you can say it is going to inhibit the LOX enzyme. Second thing we are having is your montelukast or zafirlukast. Montelukast or zafirlukast. These are your leukotriene. You can remember leukotriene receptor antagonist. These are your leukotriene receptor antagonist, right? Montelukast and zafirlukast, right? They are going to block the leukotriene receptor. They are going to block the leukotriene receptor. What are the uses of these drugs? We can use them in the cases of persistent type of asthma. First thing, persistent bronchial asthma. We can also use them in the cases of those people who are doing exercise. They will be having asthma. So we can use in the cases of exercise asthma. Exercise induced asthma, right? So we can use it in these two important situations. The side effect profile for xylitone, you can remember xylitone is hepatotoxic. This xylitone is hepatotoxic. Hepatotoxic. Whereas this most commonly we are using montelukast. This leukotriene receptor antagonist like montelukast, zafirlukast, they can present with the syndrome that is nothing but your Churg-Strauss syndrome. Churg-Strauss syndrome. They can cause this side effect. This is your Churg-Strauss syndrome. You will be studying in the pathology, right? So these are your leukotriene antagonists we can use in the cases of asthma. We can use in the cases of asthma. What about mast cell stabilizers? So basically, mast cell stabilizers, they are a type of calcium channel blocker. They are a type of calcium channel blockers. So you have studied about calcium in the physiology. Calcium, just remember three things from now. Calcium, whenever it is going to vessel, it is going to cause vasoconstriction. Whenever it is going to muscle, it is going to cause muscle contraction. And whenever it is going to go inside a cell, it is going to cause what? Exocytosis. Exocytosis means whatever content is there inside, it will be coming out because of entry of calcium. Because of entry of calcium. So these are calcium channel blockers present on mast cells. So what is going to happen? Let's try to understand. This is your mast cell. This is your mast cell. It will be having what? Histamine. It will be releasing what? Histamine, let's say. Okay. Now, whenever this calcium is going inside, then only then this histamine vesicle is going to come outside. This is known as exocytosis, and this is the function of calcium. So when this calcium is going inside, what is going to happen? This histamine vesicle is going to go outside. This is your exocytosis, right? Now what we are doing, we are blocking this particular calcium. If we are blocking this calcium, what is going to happen? This histamine is not going to come out. This is what is the mechanism of action of mast cell stabilizers, right? They are going to block the release of histamine from the mast cell. Basically, they are going to stabilize the mast cell. They are not going to make it release the histamine, right? So these are calcium channel blockers on mast cells, prevent histamine release. What are the examples we are having? We are having drugs like nidocromil. We are having drugs like nidocromil. This nidocromil we are using in the cases of mild allergies, when we are having like some food allergies. If we are having, allergic type of rhinitis, this is going to prevent the rupture of mast cells. Allergic rhinitis, and this is going to work in the cases of mild asthma. Another drug that is in the same category, we are having like ketotifen. This ketotifen will be having this particular property. Apart from that, it will have one more extra property, that is it has extra H1 blockade property, first thing. And it has extra property, that is it will increase cyclic GMP. And from now onwards, you can simply remember, whenever you will be having increase in the cyclic GMP, you will be having increase in the nitric oxide, increase in the nitric oxide. So we can use this particular drug in the cases of prophylaxis, of allergic type of asthma. So we can give the drug before the appearance of the symptoms, right? So this is the mast cell stabilizer that we are having. These are the mast cell stabilizers that we are having. Now let's talk about the inhalational glucocorticoids. Right, glucocorticoids, I have already told you, they are going to block the phospholipase A2 enzyme. They are going to block the phospholipase A2 enzyme, right? Now, what are these inhalational corticosteroids? We are having the example, you can remember, we are having drugs like fluticasone. We are having drugs like fluticasone, beclomethasone, budesonide, budesonide, flunisolide. So these are the examples we are having for the inhalational corticosteroids. The most potent out of them, this one is the most potent. This one is the Most potent. Fluticasone is the most potent. We are using beclomethasone, budesonide, flunisonide. These are the drug, right? Remember, this flunisonide is the least potent. Least potent, right? When we are going to use the inhalational corticosteroids, remember they are drug of choice. They are drug of choice for persistent type of asthma. First thing, they are drug of choice for persistent type of asthma. Second thing, if a patient is having asthma because of this aspirin, if this aspirin induced asthma is there, what we can do, we can block it directly here, right? So for the cases of aspirin induced asthma, and we can also use in the cases of like exercise induced asthma also. Exercise induced asthma. In the cases of exercise induced asthma also, right? What about the mechanism of action? Mechanism of action is simple. It is going to block the phospholipase A2 enzyme. If it is going to block the phospholipase A2, what is going to happen? There will be no COX function. There will be no LOX function. There will be nothing, right? No prostaglandin, no leukotrienes. Okay. So they will decrease the, remember, they will decrease the severity of, they will decrease the severity of attack, and they will also decrease the number of attack. They will decrease the number and severity of attack, right? But the side effect will be there. What is the side effect? So those people who are taking those pumps asthma for the asthma, they will be having what? The steroid is going into the oral cavity. If this steroid is going into the oral cavity, the patient can present with the fungal infection. That is a opportunistic fungal infection you are having. That is nothing but your candida infection. So patient can have oral candidiasis. Patient can have oral candidiasis. You will be having that pseudo membrane. You can try to peel it off. It will be coming out. That is your oral candidiasis. Oral candidiasis, right? Patient can also have changes in the voice. There will be voice changes will be there, but there will be low systemic side effect. There will be low systemic side effects. So these are the changes you will be finding. What you need to do, you need to tell the patient that whenever you are taking that this type of inhalational corticosteroids, you should rinse your mouth well, right? After taking the steroids, after taking the pump, you should be rinsing your mouth well, right? This is what is important, right? Or you can also use spacer also, right? So this is how you can use it, right? These are your inhalational corticosteroids. Next one, the question says the treatment of status asthmaticus. First of all, let's try to understand what is status asthmaticus. So this is going to be a severe form of asthma. This is going to be a severe form of asthma, which is refractory to the standard treatment, which is non-responsive, you can say, which is non-responsive to the standard treatment that we are giving. What are the things we are giving in the standard treatment? We are giving drugs like bronchodilators, normal bronchodilators like Saba Laba, and we are also using what? Steroids. So they are refractory to these two things, right? So what we are going to do now for the treatment of this type of patient, we are going to give, first of all, the patient is having dyspnea, patient is having cough. Why? Because the oxygen is not reaching to the lungs, and oxygen is the power for the body, right? Oxygen is required for all the cells, right? So what we are giving, first thing, you will be giving supplement of oxygen. Remember, the saturation should be around 92%, right? Supplement oxygen first. Okay, then you will be giving beta 2 agonist, but the high doses of beta 2 agonist. High dose of beta 2 agonist. Not via pump. This time you will be doing what? Nebulization. You will be doing nebulization, and you can also put one more drug on the add-on, that is your anticholinergic like ipratropium. bromide. You will be putting both the capsules, you will be nebulizing the patient for this particular case, right? And here you will be injecting the patient with the systemic steroid, like prednisone, hydrocortisone, you will be giving to the patient. Apart from that, one more drug you can use, that is your magnesium sulfate. Remember, this magnesium sulfate is going to relax the bronchial muscles, right? So it will be causing relaxation of bronchial smooth muscle. That is what is going to cause broncho dilation. And you will be giving patient IV fluids just to prevent the dehydration part, to avoid the dehydration, right? These are the important things. Even after this, if the patient is not reviving, you can add adrenaline. Adrenaline will be working on A for adrenaline, what I told you. A for adrenaline, A for all receptor, alpha 1, alpha 2, beta 1, beta 2, beta 3. Every receptor will be activating. So beta 2 will be causing what? Broncho dilation again, right? So you can use adrenaline. And you can also, if even if the patient is not coming back, right, what you can do, you can shift the patient to ventilator. You can use other drugs also. We are having a lot of treatment for this, right? So we can shift the patient ultimately to the ventilator, right? Ventilator. Okay. We are done with the asthma. We are done with the asthma part. The most important things we have already discussed, right? Now the question number 2 that we are having is about the pharyngeal demulcents or cough suppressants. So let's try to understand what is cough first. So what is a cough? What is going to be in the cough? Whenever there is explosion of air, whenever there is massive explosion of air, this is your cough. So there will be short, you can remember, short massive expulsion of air. Short and massive expulsion of air, that is what is known as cough, right? That is what is known as cough. What are the features when this cough will be coming out? What are the trigger, right? If you have any foreign body, what we have discussed till now in the cases of like asthma, those will be the reasons. So what are those reasons? We can have like things like histamine. We can have things like leukotrienes. They are definitely going to cause the cough. Histamine, leukotrienes, they are definitely going to cause the cough. Apart from that, apart from histamine, leukotrienes, if you are having like foreign bodies in the upper respiratory tract, you will be having what? Coughing, right? You will be having lots of secretion, you will be having coughing, right? So foreign bodies, or you can have like, you can do voluntary coughing also, right? So that is the basic understanding. So what is the mechanism of action, how this thing is working? So whenever you are having something in the upper respiratory tract, what is going to happen? It is going to stimulate a nerve that is nothing but your vagus nerve. It is going to stimulate your vagus nerve, and this vagus nerve will be taking signals to the medulla, right? It will be taking signals to the nucleus tractus solitarius in the medulla, right? And this nucleus tractus solitarius is going to cause what? It is going to activate your respiratory muscle. It is going to stimulate your respiratory muscle, your laryngeal muscle, your bronchial muscle, right? All these muscles, when they are getting stimulated, what is going to happen? Increase in the there will be increase in the contraction of these muscles, leading to increase in the pressure. And this pressure is going to be what is going to happen? Now the epiglottis is closed. When the epiglottis will be opening, this pressure will be going out, leading to a massive expulsion of the air, right? This is what is cough. It will be having 3 phases, like how we are coughing. First, we inspire, that is the inspiratory phase. Inspiratory phase. In inspiratory phase, what is going to happen? The patient is going to inhale the air. There will be inhalation of the air. Then what is going to happen? There will be compression of muscles. There will be compression. During compression, what is going to happen? The glottis will be closed. There will be glottic closure. Glottic closure will be there. You will be having expulsion of the muscles. Basically, you will be having contraction of the muscle. You will be having increase in the pressure. And then there will be expiratory phase. In expiratory phase, you will be having the opening of the glottis. You will be having glottic opening. And this glottic opening will lead to what? Expulsion of air. There will be air explosion, you can say. This is what is cough. This is what is cough, right? This is the mechanism. Whenever you are having like foreign body in the upper respiratory tract, all these muscles will be getting contracted and you will be having this particular thing. This is your cough. This is your cough, right? What are the different types of cough we are having? Then we will be discussing about the treatment part, right? So for the cough, we are having two types of cough majorly. One is dry cough, second is wet cough. One is your dry cough, second one is your wet cough. For dry cough, you will be having what? Drugs like antitussives. We will be using drugs. These are known as antitussives. These are going to depress the cough center. They are going to depress the cough center. Basically, they are going to increase the threshold of cough center. You will be having less coughing. So whenever you are having cough and nothing is coming out, that is a dry cough. That is a dry cough. For treatment also, just try to ask the patient whether you are having a dry cough, whether you are having wet cough. Wet cough means they will be feeling like something is stuck in their chest. They will be coming to you. They will be telling you something is stuck in my chest. I'm having like mucus production, sputum is coming out, right? So that is going to be your wet cough. If only cough is there, that is going to be your dry cough, and the treatment should be different, right? First, you need to ask what are the drugs we will be discussing here. We will be having like opioid derivatives, non-opioid derivatives. We are having drugs like codeine. We are having drugs like folcodeine, drugs like codeine, folcodeine. We are having drugs like dextrometharphan, noscapine, noscapine. Antihistaminics, we are having like chlorpheniramine malate, chlorpheniramine malate. We are having diphenhydramine. So these are the important drugs that you should be remembering about the dry cough. Remember, you should not give dry cough treatment to the wet cough patient. What is going to happen? He will be having depressing of the cough center. He will be having that particular sputum. The sputum will not come out. The sputum will get accumulated. You will be having other bacterial infection, other whatever etiology is there. It can increase in number, right? If the cough is going out, what that means the bacteria is also going out. Virus is also going out, right? So this is what is important, right? For the treatment of wet cough, you need to do two things. First thing, the mucus will be there. So you will be giving drugs like mucolytics. First we need to break the mucus, right? That is going to be with the help of mucolytics. So we are having drugs like bromhexane, ambroxol. We are having drugs like ambroxol, bromhexane, acetylcysteine, methylcysteine, acetylcysteine, N-acetylcysteine, right? So these are the drugs which are going to break the mucus. They are mucolytic drugs, right? And the second class we are having is expectorant. Expectorant, this is your guaifenesin. We are having drugs like potassium citrate, potassium iodide. So whatever mucus is broke down, right? Whatever mucus is there, this mucolytic will be doing what? It will be breaking the mucus. It will be causing mucolytics. It will be breaking the mucus. And now with the help of expectorant, what will happen? That mucus will be coming out. That mucus will be coming out. So if you are using these kind of drug, the patient will be having more coughing. The patient will be having more coughing, right? But when you are using this anti-tussive drugs, what it is going to do, it is going to depress your cough center. And if your cough center is depressed, that means you will be having less coughing now, right? What are these pharyngeal these drugs? Let's try to understand. Pharyngeal demulcents, these are the drugs. They are going to soothe your throat. They are going to soothe your throat, first thing. Second thing, they are going to cause what? They are going to stop the transmission of that particular vagus nerve. You will be having breakage in that signal, right? So make a note. First thing, they soothes the throat and decrease the impulse transmission of vagus nerve. Impulse transmission of vagus nerve. If vagus is not getting activated, you will be having less coughing, right? So this can be helpful in the cases of dry cough. Second thing, they will be making a protective covering. So they will be protecting the irritated mucosa. They will be protecting the irritated mucosa by making mucus coat by by coating the mucous membrane, by coating the mucous membrane. So basically lozenges, we are having, like, we are using honey, all these things are coming under this. So what are the examples we are having? We are having lozenges that you are taking, whatever, for the cough. These are going to decrease the impulse transmission to the brain, right? Impulse transmission to the medulla. So you will be having less coughing. Why? Because vagus is not getting innervated, vagus is not getting impulse transmission, there will be less coughing, right? So you can use lozenges. Second thing, whatever mucosa is irritated, it will be getting this thing will be coating the mucosa, that would be providing you the relief, right? So we can use lozenges, we are using glycerin, we are also using honey, and we are also using syrups, right? So they are going to help in this particular thing. They are going to help in this particular thing, right? Next we are having is cough suppressant. So what are the cough suppressant? Basically, they are your anti-tussive drugs. They are going to stop the cough center. They are going to they are basically going to increase the threshold. So they will be acting on CNS, and they are going to decrease the threshold for, they are going to decrease the threshold to cough center, leading to depression, you can say depression of cough center, leading to depression of cough center. So they are going to depress the cough center. You will be having less coughing now because of antitussive drugs, right? What are the examples you have to remember? We are having like opioid derivatives. I've told you opioid derivatives like codeine. Remember, codeine is the most common drug that we are using for the dry cough. This is the drug of choice also, right? We are having drugs like codeine. We are having drugs like morphine. Morphine we are using for the severe cough. These are also opioid derivatives. We are having drugs like morphine and methadone. This is what we are using for the severe type of cough. If coughing is not stopping, then we can use morphine or methadone. Morphine will also cause what? Respiratory depression. Respiratory depression. Okay. Non-opioids, we are having drugs like two things about morphine. Morphine is opioid. All the opioids we are having common side effect. One is respiratory depression. Another one I have told you in the GIT part, that is it is going to produce constipation, right? So non-opioid drugs like antico that is your dextromethorphan. We can use it in the cases of mild cough. Okay, we are having drugs like noscapine. Noscapine we will be using for spasmodic type of cough. Okay, we can use antihistaminics drugs like they're also having some properties. Drugs like diphenhydramine, phenhydramine. This is also used for the mild cases. We are having like chlorphenarmine malate. They are used for the mild cases, right? They are used for the mild cases. If nothing is working, we can use substance P in antagonist also that we have discussed in the vomiting part. That is your aprepitant. This is a substance P or neurokinin antagonist we are having that we are using for the delayed vomiting of cisplatin, right? This can also be used in the cases of severe cough. So this is about the dry cough. This is about the dry cough. That means you are only having the cough. You will be treating with these things, right? What are these things? We can use opioid drugs. We can use non-opioid drugs, right? Next class we are having is mucolytics. What these mucolytics are going to do? Muco means mucus. Lytic means they are going to break the mucus. They are going to cause the breakdown of mucus. And then we are giving expectorant that would be causing easy passage of the mucus. Right? Expectorant will expel out the mucus, whatever we are having, right? What are the examples that we are having? We are having drugs like ambroxol. We are having drugs like bromhexane. They are having similar mechanism. They are having similar mechanism of action. Basically, they cause depolymerization of mucopolysaccharides. So whatever mucopolysaccharides we are having in the mucus, it will be depolarizing them. And depolymerizing them, and what is going to happen because of depolymerization, you will be having liquefaction of the mucus. Liquefaction of the mucus. And now this liquefied mucus can be easily coming out. This liquefied mucus can be easily coming out. We are also having drugs like N-acetylcysteine. Remember, this N-acetylcysteine is also the drug of choice for PCM poisoning, right? PCM toxicity. We are having drugs like methylcysteine, right? How they are going to work? Both of them are having the similar functions. Basically, they are going to break the disulfide bond between the mucus. So they will be causing breakdown of disulfide bond. They are going to cause breakdown of disulfide bond. And this is also going to produce what? It is also going to produce liquefaction. Liquefaction, right? It is also going to produce what? Liquefaction, right? So here, these are the mucolytics. They will be causing the liquefaction of the liquefaction of the mucus. Now, this liquefied mucus, we can use drugs like expectorant. We can use drugs like expectorant, and this liquefied mucus will be coming out. This liquefied mucus will be coming out. These expectorants like guaifenesin, we are having potassium iodide, right? These things are going to irritate your gastric mucosa. They are going to irritate your gastric irritation, and this is what is going to lead to cough sensation. You will be having that particular pathway, vagus activation, everything will be there, right? So this is your drugs like guaifenesin. So now when you are going home, you will be seeing for the cough syrups that you are having. Either the cough syrup will be for the dry cough, either it will be for the wet cough. And from now onwards, how you will be treating your patient, you will be understanding first whether it is a dry cough syrup, whether it is a wet cough syrup. You will be asking for the symptom. If the patient will say, I'm having only cough, nothing is coming out, right? There is non-productive cough. That means you will be using which kind of drug? You will be using anti-tussive drug. Anti-tussive drugs will be your dextromethorphan. More commonly, we are having dextromethorphan along with the terbutaline, right? We are having other things also, right? Ambroxol drugs we are having, right? So these are the drugs. These are your antitussives. Antitussive will be decreasing the antitussive will be doing what? It will be decreasing the it will be inhibiting your cough center, and you will be having what? You will be having decrease in the cough sensation. Second thing is about the mucolytics. These are your mucolytics. They will be having what? They will be having two properties. First, they will be breaking the mucus with the help of ambroxol or bromhexin, and second, they will be having expectorant. That means this guanfacine will be releasing whatever cough you are having, that would be going out. That would be going out. Okay. So I hope you understand this, right? We are done with this. We are done with the bronchial asthma. We are done with the cough. I hope you have understood this. Try to solve the questions after this. Thank you so much for watching. And these are your download. You can download the application from here. And these are the Instagram and Telegram and all those handles. You can always connect with us for the queries that you are having. Thank you so much for all the patience. Good night.